Hey, this is Anney.
And Samantha.
And welcome to Stuff I Never Told You, production of iHeartRadio. And today we are so excited to welcome health expert, reproductive rights advocate, author of best-selling book, Grown Women Talk, and the host of the podcast, The Second Opinion, Dr. Sharon Malone. Hello, thank you so much for being here.
Yay. Well, thank you so much for having me.
We're so excited to talk to you. We have so many questions. Can you introduce yourself to our audience, please?
Yes. I am Dr. Sharon Malone. I'm a board-certified OBGYN. I am also a certified menopause practitioner. I'm the chief medical advisor at Alloy Women's Health after a 30-year career in private practice. And recently a podcaster. You know, I've done a lot of things since I left my practice 5 years ago. And I don't think anyone can accuse me of being in retirement. I hate that word, by the way. I hate retirement. I've just pivoted. New careers.
I love that. You have done so much. And this is kind of an interesting pivot into the podcasting world with the new show. Can you tell us about the podcast and how you got into podcasting?
Yeah, it's a really unexpected turn, to be honest with you. I was one of those people who, during the great COVID time, I got 3 months off from work because, I was considered, it's really harsh to be considered non-essential, but, I guess pap smears and talking about menopause weren't emergency care. So I had those 3 months off, and I had a little bit of time, a lot of time actually, to realize, I'm like, is this really what I want to continue doing? I loved what I did, and I have no complaints about that, but it just seemed like the right time to exit stage left. And after those 3 months off, decided to leave my private practice with no plans in mind. And then funny things happen when you have a little time on your hands. And my dear friend, Michelle Obama, had just launched her first podcast, the Michelle Obama Podcast, 5 years ago. And she said, you know what, why don't we talk about menopause? Because we've had countless conversations around the table, this, and talking to my friends and giving my OBGYN menopause advice. And she said, you know what, I want to talk about it. So she was really one of the first people that openly, I say first famous people who sort of claimed it and said, hey, no shame in this game. I'm menopausal. This is what I do. So that we had that conversation over 5 years ago. And once I did that podcast, it sort of opened up a world because, I'm known here in Washington, but just to my patients. And that sort of opened up a new world. That's how the founders at Alloy, which was just a startup at that point, found me because they heard me on the Michelle Obama podcast. So fast forward, Michelle and I did a couple of podcasts, and she said, and I will give her all the credit in the world because this was her initiative to say, I really want to talk about, women's health and to have a space for that. Would you do it? And so this has been a long time coming. We really started talking about it 5 years ago, and it just came to fruition this week. And we decided to do The Second Opinion. Her show is In My Opinion. So my show is The Second Opinion. Makes total sense.
Does. I mean, listening to that podcast specifically was phenomenal. Like, there's so many conversations that aren't had enough. You are really just on the beat when we need more information. Like, with all this disinformation, misinformation, and just complete erasure, especially when it comes to women's health care. Yes, this is such an important topic that's not being talked about enough. And so you coming with this podcast is phenomenal. But I also love the fact that you're talking about menopause, because as a person who is entering into possibly perimenopause, which I'm still trying to figure out and not even understanding, this is something that needs to be talked about even more in a time where people don't want to understand. I guess. What do you think when we talk about like perimenopause and menopause and as it's coming into more in conversation?
Well, I think that as women generally, we have been taught to be ashamed of so many things that our bodies do, from our periods to nursing. Everything is shameful, and it's been over sexualized or desexualized, I should say, about our bodily functions. And, it's time to say, yeah, we're going to talk about this. Why would you walk into perimenopause and menopause with as little information as women do? I mean, a generation ago, women walked into puberty that way. They didn't have any information about their periods. And then all of a sudden, all these changes start happening in your body. And then you start bleeding on top of that. And it was just horrifying. Well, the same thing happens entering, perimenopause, and we don't prepare women for it. And so when all of these things start happening and they're, the list of perimenopausal and menopausal symptoms is growing every day. I think we're up to like 34 plus symptoms. But when they happen and in no particular order, you're shocked by them, or you think that there's something wrong. And unfortunately, because you don't realize that it's all part of a constellation of symptoms, it is a transition. Women sort of parcel out their symptoms to different doctors. Oh, I'm depressed or anxious. Maybe I should be on an antidepressant. Oh, I'm gaining weight. Maybe I should see an endocrinologist. And you see how we treat the individual symptoms without realizing that it's all part of a bigger picture. And, the unfortunate thing is not only women who are caught unawares, but there is a generation of doctors who have not been trained and know how to adequately treat and counsel women in perimenopause and menopause as well. And that's the unfortunate part. When you need the help the most, and the most trusted source would be your doctor, and your doctor doesn't know what to do, then you're just really left out there on your own.
Yes. And we're going to talk about that more in a bit, because Samantha and I both have recently had some health issues.
Mm-hmm.
And we've
Welcome
been
to the show.
very open about it on the show. So we'll talk about that in a second. But I did want to, one of the reasons we knew this would be a really good fit to have this conversation with you is one thing we do discuss on the show is how often women aren't believed when it comes to the medical field, or in some cases present different symptoms than men do. And that's what's been kind of long studied or haven't been studied at all, like when it comes to a certain condition. And how that gets worse when you add other intersections like race or sexual orientation. And you dig into a lot of these issues around these disparities on your podcast with interviews from topics around birth to depression to dismissive symptoms.
Right.
Can you break down some of this for us as someone who has been working in this field for decades?
Well, the one thing that I want your listeners to understand is that the medical profession generally has been dismissive of women. And it wasn't until even 1850s that it was even deemed that the study of women's reproductive issues was even a thing that was worthy of studying. And unfortunately, it had very fraught roots. And that was with J. Marion Sims, who experimented a lot on enslaved women. And unfortunately, he gets touted as being this father of gynecology and the inventor of the field, but there was no knowledge and no really acknowledgement of the women that he experimented on, Anarcha, Betsy, and Lucy, who are the only names that we know, that helped him create the field. And this man went on to become the president of the American Medical Association. He was the founder of the first women's hospital in New York City. So, that's how we started. So you can imagine there's a lot of bias. There's a lot of not really understanding the importance and and acknowledging the autonomy of women. Women were to be dealt with. And then if you complained, you were hysterical, or it was all in your head and you were just behaving badly. Women, if you would just stop all this whining, perhaps you'd feel better. And that goes from Freud to, the medical profession, I'd say writ large, even to today. So that's a lot of infrastructure that's been built in that all of us as physicians have been trained in this same tradition of thinking that women make things up, or that all of our health problems are really psychological problems. They're not really physical problems, and not looking at the whole woman rather than just our separate parts.
Absolutely. Yes. And it's very disheartening in some ways that we're still having these conversations, but it's also, I'm glad that we are. And yeah, one of the things you talk about in your intros is being your own best advocate.
Right.
And I did recently have a pretty scary medical experience where I wished I'd had someone as an advocate, even if it was me, because it so quickly I turned it into, oh, I'm exaggerating. Mm-hmm. I was doing the gaslighting myself, which I know you talked about in the shows as well. Mm-hmm. And Samantha and I we've talked about that, where we're so ready to not be believed that it has to be like, I'm about to die before I go seek help. Why do you think it's important for women to have this information, understand this information, and the value of having a friend or an advocate?
Well, I write about this in my book, in Grown Woman Talk, because, my book is not just about menopause. It is really about how to navigate and advocate for yourself in a medical system that oftentimes doesn't see you, doesn't hear you. And so if you understood a little bit more about how the system worked and why it is that way, then it helps you better advocate for yourselves. And I think the biggest myth that we have, and, I get it, but, there's this notion that the doctor knows everything. If I feel a certain way and the doctor tells me it's nothing, then it must be nothing because the doctor knows more than I do. That's sort of the nature of the doctor-patient relationship. And it's only really exaggerated when it comes to women, but it's that way generally. The doctor knows best. Not really. So we sort of take a back seat. And I wrote the book with the intent that you understand enough. Nobody's trying to send you to medical school. That's not the point. I don't want you to argue, differential diagnoses with your doctor, but I want you to be able to clearly articulate what your issues are, and to not leave that interaction without having a concrete plan or a follow-up about what we're going to do about it. Because for someone to say, oh, you're fine. No. If you know that you're not, remember, no one is a better expert of you than you. So if you get an answer that seems satisfactory to you and you can follow up with that, that's fine. But don't ever be dismissed and then leave and continue to have that problem and not get it addressed, because that's how we get into trouble. And I think that that's how women really disengage sometimes from the medical community. And then you go to quackery, because you still are having whatever the issue is. And if you don't get an answer there, then trust me, there's going to be someone somewhere out there in the world who's going to give you a crystal amulet or, a magic herb or something. And you so want that relief. And that's the point that I want to make, is that your best option really is a medical professional. Know when to leave. If someone is not serving you, then you say, all right, well, that was unsatisfactory. I use the analogy all the time. I said, if you went to a restaurant and you got bad service, would you continue to eat there? Move on. There'll be someone else. Or, at the very least, give them the expectation in this interaction that you're an adult, that you are capable of making decisions. And let me say this to you, that the reason why I say that the whole concept of a second opinion even exists is because a lot of medicine is interpretation. We may be arguing from the same set of facts or data, but how that is interpreted may vary from one person to another. And so to imply that everything or every answer, every problem has one answer is not true. So, if you, like I said, I'm very liberal about about second opinions. And when I was practicing, I would tell my patients, I would tell them, I'd say, look, I'm very clear about what I know and what I think. And I do get to have that opinion. And it might be, yes, a little bit more informed than your opinion, but I'll at least tell you why. And then you get to decide which of those opinions makes most sense for you. And that is really the crux of how this relationship has to be moving forward, and not just someone telling you what to do. We're adults. We're grown women. I don't need to be lectured to, and I don't need to be dismissed, but I do need to be involved in the most important thing of all, which is my health.
Oh, I wish I'd found you earlier. This all could have helped me.
It's never too late. It's never too late.
Yes, yes. Something that is so great about what you're doing, and that what you focus on, is accessibility, making healthcare more accessible, because a lot of it is very complicated and very intimidating. And so when you're trying to understand it as someone outside the medical field, it can just be so complicated. And a lot of the stuff you talk about on the podcast is very complicated, but you explain it in a way that is understandable, not condescending at all. Very like, okay, I get this now. I have the facts, and maybe I can understand more about what's going on with me, or what have you. How did you come by that skill, and what are the challenges of it?
Well, I was a regular person for a lot longer than I was a doctor. And I have been on the other side of that desk, with family members and with friends. So the one thing that really struck me was that if you listen to two doctors who talk to each other, we really do have a different language, and I understand what someone's saying, but the person who's sitting there next to me that I may be there with, a family member or a friend, I know that they don't understand that. And I think for a lot of doctors, they forget that you're talking to regular people, and that we're using terms and we're saying things and we're throwing out numbers and facts and figures that don't make sense. And so there's a way to have that conversation, but to have it in regular person speak. And so I've always just sort of approached how I speak to patients, how I would speak to another adult who perhaps we don't speak the same language, but I think I can be an interpreter. I can take doctor speak and translate it into regular person speak. And it doesn't mean that is condescending. You're not speaking down. You're just making sure that people understand what you're saying. And, for those of you who don't know me, I have a musical reference for everything. Throughout my book, I have a playlist, I have music in there. And there's a line from the great Erykah Badu, and she says, "What good do your words do if they don't understand you?" And that's sort of the approach that I take when I'm talking to patients. I've always been of the mind that people are capable of making good decisions for themselves if they are presented with facts that they can understand or options that they can understand. But a lot of people, I think, go in, and particularly of my generation and before, they expect that the doctor's just supposed to tell you what to do. And no, it's a partnership. And you and your doctor should be in this together. And our goals are the same. And it's to, resolve whatever issues you may have. And, and I think for me as a doctor, there should be an element of humility. I know what I know, and I know what I don't know. And when I don't know it, then I'm going to make sure that I get you to someone that does know it. But I would never say, because I can't figure it out, that it's unfigure-outable. I may not know the answer, so let's go figure out where we can get you to someone that could get you a better resolution than I could.
There's so much in that conversation of like you being willing to say, I don't know. I feel like that doesn't happen enough in any profession. If someone thinks that they're a professional, they truly believe then they are the end all. And not enough people are willing to say this is wrong. And I think we see that as a whole when it comes to any kind of system, but in the medical field, especially right now, especially as we're trying to navigate insurances that have monopolies, as well as the decreasing in Medicaid and Medicare, or like what's being covered and what's not. Overall, there's so many things, especially in the U.S. I guess we need to keep that regional in this speak and in this time frame of hellscape that we are in. That right now, everything seems like it's getting worse for the normal person, a person who is covered by the insurance system, whether it be the affordable healthcare or whether it is Medicaid or Medicare. What do you see are some of the biggest failures that are happening? And what do you think may be some of the fixes? Or are there fixes like, I don't know, when we were talking about with COVID times, we have now telehealth, but that's slowly slipping backwards. But things like that, what could be some of those fixes?
Well, I tell you, we're at a very serious inflection point now, just in healthcare delivery, healthcare costs, a lot of things, and there's a lot that contributes to that. And that is, one, we are facing a current and increasingly worsening doctor shortage. Okay, because we're just in my field alone, in OBGYN, we're going to be in relatively short order about 5,000 OBGYN short. But even that 5,000 doctor shortage is not evenly distributed. There are over 50% of the counties in the United States that do not have a practicing OBGYN. We have a shortage of primary care doctors. The aging population, the over 65 group, is the fastest growing demographic. And we don't have geriatricians. We don't have doctors, solely devoted to aging patients. And so the kind of care that you're going to get is spotty. Where you live is going to determine whether or not you have access to quality health care. And even if you're in a place like New York City or Washington, D.C., the shortages are here because it's affected by whether or not you have insurance. There's so many doctors that are so frustrated with the system and the insurance market that they are coming out of the insurance marketplace. So you get a really good doctor and they're frustrated and they say, you know what, I'm not doing this anymore. I'm going to be a concierge doctor, or I'm going to be fee for service. So that bottleneck that already exists because of just the changing demographics, it gets tighter and tighter. Women who are increasingly, a larger percentage of the doctor workforce are leaving in droves. Young women who are in their 40s, I at least was 62 when I left, but women who are in their mid 40s are saying, you know what, I'm out of here. I'm done. I'm finding an exit ramp, and I'm going to do something that's maybe medical related, but not direct patient care. And that's creating, it's creating a chasm between the need and being able to meet that need. So what are we going to do about it? Well, we can't clone doctors, okay? But I think what we can do is realize that this is the time where we have the technology and we have the wherewithal that we're going to have to alter how we deliver care. Just like we changed, 50, 60 years ago where a doctor used to make a house call, guess what? We don't do that anymore, and patients got used to it. Well, now we're sort of understanding that there are a lot of things that can be done in a digital health space. Not everything requires an in-person visit. Yes, there are things that do, but the things that don't, we're going to have to offload that. We're going to have to harness technology. We're going to have to use artificial intelligence intelligently such that we can meet the needs of our patients. And it's going to involve sort of broadening the population of healthcare providers. It will be nurse practitioners. It'll be physician's assistants. Because the point is that you get what you need. And doctors do a lot of things, and particularly OBGYNs. On any given day, we're a social worker, we're, a psychologist, we're a marriage counselor. Oh, yeah, and we deliver babies and do surgery. And we're supposed to talk to you about menopause, which is a thing in and of itself. And to be honest with you, it's just too much. And so we're going to have to figure out, how do we reorganize? How do we get more efficient? That's why, when I left my practice, I wasn't done being a doctor. I was just done working in that particular space. And so when I had the opportunity at Alloy to be in on the ground floor and to say, all right, if we're going to do menopause, how would we reimagine getting that care and the accessibility to women who need it, and to do that affordably? Those were the two missions at hand. And I think that we've done that. And this is just the tip of the iceberg, but there's a lot of stuff that we're going to see in the next few years that, is really going to involve technology. And for your generation, who's really, you're already digitally savvy and you know how to do this, it won't be odd to you. Just like it was not odd to me. Why would I expect the doctor to come to my house? That would be ridiculous, It'll be the same thing. Why do I have to take a day off from work and go pay money and sit and pay for parking and wait for an hour for a doctor to tell me, you're fine?
Yeah.
Maybe I am, maybe I'm not. But did I need to do all that for that?
Yeah. Oh, pay for parking. That annoys me to no end.
I know.
I don't know why, but that was just like the cherry on top.
If I heard one more time a patient ask me, do you validate parking?
Yes.
No, we don't. We don't validate parking.
I will say for our healthcare person, they told us at the beginning, did you park here? All right, we can validate. Like they just were already done.
Oh, we didn't. Oh, if we validated parking, we'd go into negative dollars for the visit. It's like,
oh, there's so many things. I have to ask. Let me ask you what your thoughts are on medical tourism.
Oh, you know what? It's scary to me.
I like the way you begin as if it was like, oh yeah, no.
Because I don't, let me say this. Let me tell you, this falls in the category of what I think, now what I know.
Right.
All right. So I would be very wary of going to another country. Maybe it's fine. Maybe it's not. But again, it tells you the lengths that people will go to to get care for something because it's so out of hand here.
Mm-hmm.
And I hate to be the bearer of bad news, but once the price of something goes up, it very rarely goes down.
Mm-hmm.
All you can do and hope for in medicine is that we pump the brakes on some of it, and maybe, but I'm going to go back a step farther, and I'm going to say something that doctors would probably like not to hear me say, but it's true. Doctors have to make a living.
Right.
I get it.
Right.
And unfortunately, this is the vice grip that doctors are in. You go to school, you've got a mountain of debt when you get out. Basically, you get out of med school and you've already bought your first house, and it's called, here's my medical debt, my tuition debt from med school and college. And you're in this constant push and pull with insurance companies. Insurance companies will tell you, I don't care what you charge, this is what I'm going to pay. So, it may be 50%, it may be 30% of what your charge is. So there's this real economic pressure that doctors have. They're high, and let me say, highly trained professionals. They deserve, their time is worth something, but you have someone else who is telling you what your time is worth. And so many of the medical practices now, as a physician, I was not just a physician. I was a small business owner. Our practice was independent. We ran a practice. We could make decisions about what days I was going to work, what days I didn't want to work, how off, and it was all sort of based on what my particular needs were at that time. And now that so many medical practices have been bought by private equity groups, or they've been subsumed by large universities and hospital groups, doctors are no longer in control of their time. They're not. So you're being told now, okay, you're going to see, this is how many patients you're going to see a day. This is what your productivity plan is about how you get paid. That's very disheartening for people who have been medical professionals, thinking that you're going to have some autonomy, and you don't. Most doctors now that you will see, and you can check this out, most of them are employees, or somehow or the other, they're not in control of that. So there's a real economic pressure, and people will do sort of a lot of machinations around the system because the repayment schedule is so complicated that there's a tendency to say, okay, well, you're only going to pay me 50% for this and 20% for that. So I'll just put as many things in there as I can to charge for, in the hopes that in aggregate, it'll end up being just a fair price for my time and my work. And those are the games that we play with insurance companies. That's the game that we play with Medicare and Medicaid. But at the end of the day, no one has yet said, this makes no sense. Why don't we decide what's fair, what's accurate, how to do it so people don't have to play these games? But I'll tell you who gets hurt by that. Okay, you have your insurance. So you go in, you pay, you get your copay, or you have your surgery or whatever. The insurance company, let's just say they pay me 50 cents on a dollar. You, Samantha, come in with the same issue. You have the same procedures done, but you don't have insurance. Or you have insurance that has a really high deductible. Guess what? You have to pay 100%. You don't get a discount because I say, well, you know what? This insurance company is only going to pay me 50%, so you pay 50%. No, you pay 100%. So you see what I mean? So you've got this patchwork system where the people who get hurt the most are the people who can afford it the least, because these are people who can't afford insurance, or for whatever reason, are caught in that gap. Maybe you're between jobs. And, so it's not an accident that the number one reason for bankruptcy in this country is medical debt, because the people that can't pay, what are you going to do? You can't say, well, that's all right, I'll just die. No, that's not an acceptable answer to that. So, our system's broken. That's the bottom line. It's broken. It's unnecessarily complicated. And, the best example that I can give you, and you may be too young to remember this, but I'll tell you because I remember in the old days, what's about to happen to doctors is what has happened to pharmacies and pharmacists. Okay. There was a time in the not too distant past when pharmacies were independently owned. You went to your corner pharmacy. The pharmacist there was usually the owner of the pharmacy. They are trained professionals. They were back there. They weren't just, taking a pill out of one big bottle and putting in a little bottle. They were doing things. They knew. They would counsel patients. They would actually compound things back there. So it was a very different pharmacist that you were looking at now, and very well respected in the community. Well, what do you think of now when you think of a pharmacist? Do you think of, they're just back there, they're working at, name any pharmacy, CVS, Walgreens, or whatever. In your eyes, they're a technician. All they're doing, what are you doing? It's like, how hard could that be here and there? And so we have sort of devalued the profession, even though those people are just as highly trained as the pharmacists, probably more so because they have more things to think about from 50 years ago. But you don't think of that pharmacist at CVS as someone being, this person is going to give me some advice and go make me something if I can't take it. I used to love the pharmacists here because my children, children don't like to take yucky medicine. And he would actually compound their antibiotics. So it would be bubblegum flavor, or it will be this or whatever. He would make it and loved it. No, they don't do that anymore. And so medicine is becoming where I think doctors' time is devalued. And I don't think no one went into medicine because they wanted to do a bad job or be dismissive. But if you're under that pressure, oh my goodness, I've got a patient every 15 minutes, then you, Anney, needing more time, that may or may not happen, or it's just say, come back another day, and now another parking, another half day off from work just to get your questions answered. There's a better way. And we just got to, we have the tools. We've just got to figure out how to put it all together.
Yes. I recently had an experience where I'm trying to find a doctor, and I went to a place near me, and there was a sign on the window, and it was quite long, and it was about how they do insurance.
Mm-hmm.
And I just remember thinking, yes, there's got to be a better way than this, because clearly the doctor's frustrated. I can't understand any of this. So
to this day, I do not understand. There's so much about insurance that I don't understand. I'm like, wait a minute, what? You get, when you go to a doctor and when you file your insurance and you get what's called an EOB, which is an explanation of benefits. And I call it's confusion of benefits. I'm like, I don't know. So wait a minute, that didn't get paid for what? And it is a system that is designed to confuse you. It is designed to not pay the doctors in a timely fashion, but also to get you, the more you deny a patient, then you've got to decide, is it worth it for me to be on the phone for half a day trying to get the answer to this? And increasingly for a lot of people, you're like, you know what, it's not worth it. If it's below a certain amount, you're like, whatever. And so who wins? Who wins? I'm not going to, I'll leave it at that.
Well, going back to the technology aspect, because it is true that a lot of us have these we know how expensive going to the doctor will be. And so where do we go first? We go online, and we're trying to figure out how serious is this? And one of the interesting things of working on this show is, like, for instance, with heart attacks, we know that symptoms for heart attacks look different with women. And so I know that going in, but if I can't find the great information about how different they look, then it's almost just as confusing, if that makes sense, because I don't know anything at all. And so I'm just curious, because it's interesting that we've reached this point where we know there's a difference, but maybe not quite what the difference is. And then on the other side of that, when I recently went to the hospital, they told me, like, oh, you're too young for this and you're just stressed. And that's something you talk about in your podcast, is the kind of the expectation the doctor might have of this is what a patient of this looks like. Right. So can you talk about all of that?
As doctors, this is sort of how we're trained. There's so much to know. And honestly, learning an individual requires that I have some experience with you. I've seen you once. In my practice, I had seen patients, I've taken care of them since high school through menopause. I know your mother, I know your children, I know your family. So I have context. I don't just have a random string of facts about what this looks like and what that looks like. I know that you, Anney, complain all the time. Samantha, you never do. So how to interpret what comes in from that. But so much of how we make decisions and make diagnoses is really heavily dependent just upon pattern recognition. I have to know that who's at risk for this, who's at risk for that, what are the symptoms, how do they all hang together? But it's a pattern, and we have been taught to have a picture in our mind of who presents with what. And that's just built-in bias, because that means that just because you don't look like the textbook picture for that thing, that you don't have it. And that's what we lack, is really the context and the ability to sort of go beyond the superficial. And that's where a lot of racial bias really gets built into the system. That's where a lot of the gender bias gets built into the system, because you're thinking, well, for time immemorial, all we had to base these symptoms on really were men, and women weren't even included in clinical trials until 1993, which was, 1993, my first daughter was born in 1993. So I'm like, that wasn't that long ago. But women weren't included. So a lot of the things about how symptoms present in women We're just really sort of understanding that because we never really looked at it or paid into attention. And I didn't coin this phrase, but, it's out. I forget who did, but this notion that women are not small men, and how we present is very different. We can have the same condition like heart attacks. And when we talk about, and this is how biased the conversation is, when we talk about heart attacks in women and heart attacks in men, the language is, well, women have atypical symptoms as we present for heart attacks. And it's like, well, really, are they atypical? Or are they atypical for men? Because you're using that sort of pattern recognition pattern and putting it on and overlaying it on women, and it's not the same. So we are now just becoming aware of the fact that women present differently, that different points of our reproductive lives. I mean, that's why we've had so much of an issue with menopause and not understanding that menopause in and of itself is not just a reproductive issue. It's not just the end of your periods, yay. It is a total body experience that has effects from your hair to your toes and everything in between. And we haven't really taken into account how menopause and the change in your hormones affects your body composition, your bones, your brain, your heart. Whether or not you're diagnosed with diabetes, all of this stuff is hormone dependent, and it's different for women than it is for men. And then we also, have, when you're at the intersection of gender and race, then it's even more ridiculous because we have a picture in our mind of who we think has endometriosis. It's a thin white woman. We have a picture in our mind of, who has depression and anxiety. We have, so all of these little shorthand notes that we use will leave out a lot of people. And that's what we're really trying to address, is to realize that, look at the person, not the stereotype, and listen to what they're saying. And a lot of times, again, that requires time. But we have an opportunity, and I think a huge opportunity here, because if we were to address this and how we build these large language models for AI, we can either build that same bias into the AI, or we can take it out of that. We can make the intake race neutral. I don't have to look at Samantha and say, oh, well, here's an Asian person and here's a Black person and here's this person. So these things, because again, it really sort of gets us on a path that sometimes is hard to get out of. So I think that, again, with technology, it's a huge opportunity if we build them correctly. Because, as we say, garbage in, garbage out. So if you put the same, thing in that what we've been using and what we've been taught, you're going to come up with the same output, which is unfortunate. But it's a huge, huge opportunity. So, I think that the more informed any person is coming into a doctor's office, the better that interaction is going to be. And you can be informed without being aggressive or confrontational. Ask good questions. Make the doctor think about it. Well, maybe you didn't know that my mother had whatever, or my family history. I may not look like a person who has osteoporosis, but my mother broke her hip and she's in a nursing home. Those are the kinds of contextual things that sometimes doctors don't have the time to ferret out. But if you put them in a system that takes all that into account, then I think you're going to get a better outcome.
Right. I mean, that's a big caveat if they train appropriately.
Yeah, but you know what? And this is where I think it's important that doctors get involved. Don't let other people who are developing this, who are really, all right, say, yeah, you're out there to make money. Doctors are we're technophobes. Let me just say, how doctors are still complaining about electronic medical records. But that's a classic example of what happens when you develop a system that doesn't really take into account how doctors actually practice medicine.
Right.
it's onerous. It's worse now than I think it was when you had a paper chart, just simply because, of all the things that you took into account, you didn't take into account, well, how does this fit into a doctor's workday? How about, you may have a very thorough chart that you've asked everything, but you have to ask yourself, is a doctor, every time that patient walks into your office and it's a different doctor seeing you, are they going to read the 57 pages that were generated from your last visit?
Right.
Probably not. So that's why I said opportunity. And I urge all my physician friends who said, don't let these things get developed without you,
right,
without taking into account the things that we need to fix.
Right. And that's why it's important to have a diverse group
of
people when it comes to being in these fields.
Exactly.
And then, you brought up heart attacks, and I've told the story before. So I'm adopted. My mother is white. But at the age, late 40s, early 50s, she started having weird symptoms. I'll put in quotes weird, in that no one could figure it out. She went through 4 to 5 doctors. She had jaw pain, all these other things. And it wasn't your typical thing. She was not necessarily overweight. And when she finally went to a final doctor, they were like, oh my God, let's do a scan and all these things. And they realized 94% of her widowmaker, of her heart, was clogged as she was on the precipice of having a massive heart attack. And it took months for them to even figure this out. And again, this is 2005 to 2007, so not that long ago. When I say 20 years ago, it sounds like a long time ago. But when you put it in context of in the it was still the 2000s that they did not understand. The modern doctors, so we're from Atlanta. She was going through all the specialists in Atlanta, did not understand until months later that she was about to die. They were oh, because she was a woman with quote unquote atypical symptoms. And we know people are finally starting to talk about that. We see campaigns coming out and conversations about all these different things. And we know a part of that is due to the grants and the diverse programs that have been out there because of DEI and all these other things. Now we're watching all these programs slowly come back, even striking out any programs that have the word women, God forbid, or that. Should we be concerned about these rollbacks when it comes to finally being able to say, let's study women, let's study people with uteruses?
Oh, I could not agree more. I mean, we're finally at this inflection point where we were going to say, wow, we haven't had a study, a large scale study on women, and particularly postmenopausal women, since the Women's Health Initiative. And that was almost 30 years ago that study was initiated, and it was stopped 23 years ago. Large scale, learned a lot from that, misinterpreted a few things. So there's that. But it was really the first time that anyone said, okay, let's look at women. Let's look how women, and even a lot of the heart data, the cardiac data, the reason why it's so difficult. All right, so 1993, you've got to include women in clinical trials. Okay, but before that, the face of a heart attack was, an overweight Black person with hypertension, or it was a type A white man, who was in his 50s and 60s. So a nice, trim 47-year-old woman, it's oh, no, it can't be that, because you don't fit that mold of what we're trying to do. But to be able to do that, it really requires that when we look at the data, when we look at when we're evaluating any medication, including women in trials is one thing, but you can't lump them all together in your results. Because if it works really well for men and not so great for women, but you smash them all together, it seems like it's working, and to say that you can't disaggregate data, and this is sort of where we are now, by race, or we can't disaggregate data by gender, we are losing valuable information, because guess what? Things don't work the same in women as they work in men. We do have a totally separate hormonal milieu that medications have to work in. And that's my fear, that even if we have women in trials, if you don't separate them and report out separately, we'll lose a lot. And then when it comes to race, the same thing is happening in race. It's like when it says, if any studies that say disparities or race or gender or any of the things that these charged words, then if we're not going to study them, then how will we know? I mean, and one of my issues that I work on a lot is that is the racial disparities in healthcare in this country. And they are bad, and they've been bad. It's not like this is a new situation here. You would think that the disparities, and all that means is, what is it for the majority population and what is it in African American? Name anything and it's worse. And it's not just maternal mortality. That's the least of the issues in terms of the disparity. Heart attacks, strokes, Alzheimer's, obesity, any chronic disease. And you can use that same 2 to 3 times multiplier. We've known this for as long as we have kept healthcare statistics. The only thing that's happened as we've gotten better at treating things, the overall numbers have gotten better for everybody. Breast cancer used to be a death sentence, 75 years ago. Guess what? It's not now. 90% of women who are diagnosed early will live. Yay. But guess what? The disparity still exists between Black and white women. And the better the treatment gets, here's the little conundrum here. The better the treatment gets, the larger the disparity gets between Black and white. And that is because you don't have access. It's not like you got some new genes and all of a sudden, you're doing worse. It's the environment that we find ourselves. It's lack of education, is lack of access to quality care. All of those things are far more important than anybody's racial composition. You could take a poor white person from Appalachia, put them, and look at those and say, "Whoa, those are worse too." Do they have different genes from another Scottish American who is living in New York City? No, they don't. But their environment is different. And I think that unless and until we stop blaming individuals or individual racial groups for poor outcomes on poor behavior, if you would just stop doing on any number of things, you'd be better. And just understanding that the problems really exist outside the individual. And those are the things that we choose not to address. It's not that we can't. They're quite figure outable, and we've known them forever. We just do nothing about it. And you can go through study after study after study from when I say the early 1900s to today, and those same disparities. And the only thing that's changed is, like I said, the overall numbers down, the disparities still exist.
Yeah. And we've talked about this before on the show. There's a lot of moralizing around. Yeah, you should. If you just ate correctly, if you exercised correctly, this is all right on you. I remember my dad, he was diagnosed with cancer, and they told him, you should have been coming in for a check every year. And he had been coming in for a check every year. Yeah. But kind of turning it on the patient. And Samantha and I have kind of talked about that a lot, of having bad doctor experiences and trying not to get turned off by that. So as someone who is looking for a doctor right now, what are some things you think people should look for? They're trying to find a good doctor.
I'm going to tell you, Anney, and it would take too long to do this, but I have that's the whole first chapter of my book, is how do you pick a doctor? What do you even look at? Where do you go? How do you evaluate them? And it's very actionable items, because here's the other thing that you say, okay, well, go on the internet and whatever, but there's so much information. How do you know what's good information, what's bad information? How do you know someone's telling you to do something and then someone's telling you to do the exact opposite of that? So what I did, in addition to giving really concrete advice, is that I have references in the back of my book and resources. Just resources. So I'm like, if you're going to go and you want to know about, how do I evaluate my doctor? How do I check and see, does this doctor have, 150 lawsuits outstanding? Do they have a DUI? Any of those things. You can go to those references and say per chapter and look at them and say, all right, this is how I evaluate it. But don't discount your gut. Okay? Because you can have the most credentialed doctor in the world who is an asshole, and if they make you feel like, whatever, and put you off, then that's not a good fit. So it's not just the credentials. That's a minimum. Is my doctor board certified? Do they have other issues that are outstanding? And then you go from that to, okay, then what do I feel in this interaction? And trust it, just like you would trust anything else. And when you're in a doctor's office, you should feel seen, heard, and respected. And if those three basic things can't be met, then it doesn't matter where your doctor went to med school. It really doesn't.
I haven't thought of that as a process, but now you're making me think of things about self-respect in doctors. Okay.
Mm-hmm. That's the minimum. Right. We as doctors, no matter how we want to see ourselves, we're in a service industry, and my job is to make sure that your needs are met, however that needs to be done. And, and occasionally, and I will say this, occasionally sometimes I will have something, or there'll be something that's so specific that, sometimes you might need to see that asshole. If you've got, and I'll give you an example. My daughter, and I happen to have a lovely neurosurgeon that I sent my daughter to, but sometimes it's like there are people that what they do is so specific, and yes, you need common things you don't need to see that person for. But if you have that one thing that this person is the world expert in, and you're going to see them, once or twice and get that resolved, then hold your nose and see them. I get it. But I warn patients before I see them. I'm like, I'm just going to tell you, he's a little bit of a jerk, but we need this fixed. And he or she is the person to fix it. And I say that sounds very sexist, but it is true. But it is usually a he who's a jerk.
Yeah.
I said it. But you know what I mean?
Yep.
And so that's why I said, know your mission. What am I there for? Is this someone I'm going to spend the next 20 years with? Then no, you need a better person that you have a rapport with. Right. But if it's something I'm there for, a specific thing, and this person is the best in the world at that thing, then do that.
Right.
Deal with, then talk to your other doctor later about it.
Look for the results, not necessarily for a pat on the back. I like it. Well, I'm going to tell you this, like having you on the show is a dream. And obviously you are a podcaster's dream, especially when it comes to intersectional feminism and in this conversation. And I know you are now in this podcasting world. You've been in this podcasting world for a minute. I mean, again, you were with Michelle Obama talking about so many things. But as you are in this world officially with your podcast being released, what are some of the takeaways you have from doing this podcast and or from the interviews? Like, have you learned something new or something that was like stood out to you already?
Well, I hope to learn a lot of things because, as I said, I don't know everything. I know what I know, but I have a very low bar for things that I don't know. I will do the vetting for you because, see, I will get the experts that I know and trust, and I, think that there is an opinion that is worth having. So that's the whole purpose of the second opinion. I will learn things, about things that I don't treat. So it's not just a show about menopause. It is about all things women's health. So we will talk about gynecologic things. We'll talk about heart health. I have a whole show that I loved on GLP-1s because that's something, even at the time I wrote my book, I hadn't really taken care of anyone who was on GLP-1. So I didn't really, and I was very clear about that. I'm like, I don't really know. It's not my thing. But now I understand some things about GLP-1s now, talking to an expert that I didn't know going into it. So that's it's going to be two-pronged. There'll be things that I want you to know some experts and to see what the experts have to say about it. That's my second opinion. And then as a result of that, we all get smarter. I'll learn something I didn't know either. So, next time someone asks me, I'll know what
Be
to
ready.
say.
That curiosity is so valuable and refreshing too. Like going back to admitting what you don't know and what you do know and being very clear about that. And one thing that I got when I was listening to the podcast was I did feel really empowered and validated of like, okay, so I'm not the only one who thinks this. I'm not the only one who has all these questions about this. And maybe we don't have the answers yet, but at least I'm not the only one who's asking these questions. And I think that that's something that I know is important to you, is empowering women, people to make these healthcare decisions, to have this knowledge, for it to be more accessible. So what is it that you're really hoping people take away from this podcast?
I am hoping that at the end of every episode, that you'll walk away with some knowledge you did not have at the beginning, and you'll be able to use that knowledge to effectively advocate, maybe not for you, but for your friends. So the next person who comes up with that and say, you know what, perhaps you should take a look at this, because it's so important. And the message I want to give is not gloom and doom. Oh my God, women, we have so much stuff and it's going to be terrible. And, getting old is horrible. No, it's not. I mean, I don't mind saying it. I'm 66 years old, and I've pivoted. I'm doing different things in life. I feel as good now as I've ever felt. But I also want that to be the expectation. If I say, where do I want you at 40 to start thinking about your life at 60? I want you to think of it as something great, not something, like, oh, then what am, no, don't think that the inevitable is decline followed by death. It can be, but just know that you have the ability to change that trajectory, regardless of what your family history is, and regardless of what your current health situation is. You can make it better. There's never too late to start, but I like to get people really early in this process and get them invested in their health and making them understand that, oh, okay, your mother had breast cancer. I've had 2 sisters with breast cancer. That doesn't mean I'm going to get it. I may or I may not, but understand the things that I can do along the way that minimize my risk. Nothing is inevitable. There are very few things that are strictly genetic. Very few things. And even with genes, how those genes interact in the environment that you're in matter. So, I think that overall, the message that I want to have is really a hopeful one. And that I want you to feel is that, yeah, I feel empowered, because the course of my health is going to be determined by what I do, not what someone does for me after the fact. So there's a huge prevention message that I want people to get. And I think once you explain to people why it's important, you get compliant. I mean, people will comply. No one wants to feel bad. And I have always found that to be a much more potent motivator when I'm talking to my patients, to tell them why, not just do it. And then you know what? Most of them do. They hear it.
I love that. Yes. And as we said, it has been such a needed conversation. Very glad it's happening right now. And you seem like someone who has a lot of stuff going on. Do you have any other things on the horizon that you're excited about, that you want to talk about?
Oh my God, that's enough. I mean,
that's fair.
I still, my heart is always with the menopausal woman. So I love my perimenopause and menopausal work. And I will continue to do that with Alloy, because again, my mission is access and affordability. It doesn't do anyone any good to educate you about all this great menopausal stuff or whatever. And then you're like, oh, great. And then you can't find a new place to go. So access is important to me. And, and so I will always continue to do that. I hope that the podcast is helpful and that's my goal, because I have no, I cannot say that I harbored a secret desire to be a podcaster. That wasn't on my bingo card. But if it can serve a purpose, then I'm all in. And I really want listeners to understand, same thing. I want to hear from them. I want to hear, what do you want to know about? Because remember, you're only going to get that 15-minute visit in your doctor's office, and only about 5 to 7 minutes of that is spent with the doctor. So what are all the things other than that 5 to 7 minutes that we can sort of help expand during this time? And that's really my goal for the podcast. And if I can do that, then, hey, I've done my job.
Yes. Yes. And it's such important information, because no one teaches you that. No one teaches you how to go to the doctor and what to say and what to do. And
and we're going to shed all this shame and stigma about women and women's bodies, And the one thing that I'm really encouraged by is that I just did, oh my God, I did 3 events in New York this past weekend. And over the years, the number, just the appetite for this conversation is growing. And women are so grateful to be able to have it. And I'm just amazed at the things that people will say out loud. Let me just say, 20 years ago, no one would have ever said these things. They'll get out there, open mic. Oh, and by the way, I was having, and I was like, oh, okay. Well, I'm not embarrassed, and I'm glad you're not, because we're just going to put it all out here and answer these questions. But the one thing I want also people to understand is that women's health is everybody's issue. It's not just women's health, because what are we? We're the center of focus in families. We're either caregiving for elders, or we're taking care of children, or we're navigating the healthcare for everybody in our space. So keeping us healthy and happy should be everybody's goal. It's not just a women's issue. Men should be out here advocating for this as well. And men need to be educated about menopause, as do family members, so you can have a little bit of grace and understand what's going on in this space without thinking, again, don't perpetuate those stereotypes. Mom's crazy, oh, I can't believe she's so out of control. Those kinds of things that we have been saying about women in perimenopause for way too long. We're going to have to shed that. And I think that the more we know, the more we're able to navigate this space, not just individually, but collectively. There is, for your perimenopausal and menopausal women, because the one thing that has been a problem is the lack of research and the lack of federal funds that have gone into conditions that affect women, not just menopause, everything. $45 billion in 2022, less than 11% of that went to conditions that affect women exclusively. We're 51% of the population. How do we get 11% of the budget? And that includes, polycystic ovarian disease, fibroids, migraines, autoimmune diseases, all these things that disproportionately affect women that we have just said, oh, well, women, what are you going to do? That's no longer an acceptable answer. So we want to make sure that people know how to effectively advocate, not just for yourself, but again, collectively, or what I call the big A advocacy. Write your state legislators, write your governor, write your Congress people. And we have bills now we have bills in Congress, so good luck with that, right? But they are there waiting to be voted on, but just really to elevate the issues of women's health. As I said, it's in everyone's best interest. And for those who want to have an idea of what to do, there is the Citizen's Guide to Menopause Advocacy that actually lays it out. You can just, Google it, find it, and it actually lays out, what do you say? What do you write? What are the things that are important? And it makes sure that's how we're going to move the needle. We're going to really have to, advocate for ourselves collectively, in addition to the advocacy that we have to do one-on-one in doctors' offices every day.
Absolutely. And we have loved having you on today, Dr. Sharon. This has been so fantastic. Thank you for being here and for all of the great information. Where can the good listeners find you?
I'm on Instagram, SMaloneMD. I have a website, so if anybody has questions or things that they would like to submit, that they'd like to hear about in the second opinion, you can go to my website, DrSharonMalone.com, and go to the second opinion tab. And it will also have, things. Sometimes I will do in-person appearances, places. And so you'll have an idea of what's there. And then you'll also know upcoming episodes in TSO, and also put in requests, because I want to answer questions that people have. And so the more I know what you're interested in, the more I know about who to go out and answer those questions for you if I don't know myself. And I want to hear real women's stories too, not just the experts. I want to hear real women talking about real problems.
Yes. And your podcast, The Second Opinion. Go check that out, listeners.
Yes, The Second Opinion. You can get it wherever you get your podcasts, Apple, Spotify, YouTube. And it's out there and it's in the world. And we have 2 episodes out now, and there will be a new episode every week, every Monday. New topic.
Awesome. Well, thank you so much for being here. Hopefully we can have you back again. We would love to talk some more.
You can have me back again, of course. See, this is easy. I didn't have to get dressed or anything. See, if I'd known that, I was like, yeah.
Well, next time you'll know.
I'll do this a couple times a week. No makeup, no problem.
Come on.
I love it. If you would like to contact us, you can email us at hello@stuffmonevertoldyou. You can find us on Blue Sky, Monster Podcast, or Instagram and TikTok at Stuff One Never Told You. We're also on YouTube. We have new merchandise at Cotton Bureau, and we have a book you can get wherever you get your books. Thanks as always to our super producer, Christina, our executive producer, Maya, and our contributor, Joey.
Thank you.
And thanks to you for listening. Stuff Never Told You is production by iHeartRadio. For more podcasts from iHeartRadio, you can check out the iHeartRadio app, Apple Podcast, or wherever you listen to your favorite shows.